Hello everyone, I'm Dr. Ali Bozorgi, cardiac electrophysiologist, and in next 20 minutes I will discuss about Crux PVC diagnosis and ablation. Why I chose this topic? Because it is not talked about much in our meetings and it's rare condition, but I think it could be a significant reason for unsuccessful PVC ablation. Another reason is that ablation in this region is tricky in terms of access, in terms of radio frequency settings, and in terms of complex anatomy that is present in this region. It may be not too rare because in old PVC registries you will find that up to 80% of all PVC were right-sided, while unsuccess rate was about 30 to 40%. So lots of unsuccessful PVC ablation were actually left-sided. In new PVC registries, there are reported 60% right-sided PVC. Unsuccess rate is about 1 to 15%, depends on the center's experience and honesty, and a big portion of unsuccessful PVC ablation could be epicardial, like Crux PVC. About terminology, Crux cordis or cardiac crux is the area on the lower back side of the heart. Crux in Latin means cross. When you look it up in normal dictionary, you will find another meaning for crux, the decisive or most important point at issue, a particular point of difficulty. Look, there is some ironic meaning for choosing such a name for the PVC in this region of the heart. Let's talk about anatomy. The cardiac crux is a four-sided pyramidal space located in the posterior septal region and is bounded by right atrium, this part, left atrium, right ventricle, and left ventricle. This space contains major structures such as posterior descending artery, a branch of right coronary artery, and AV nodal artery, and also you can find middle cardiac vein in this region. Here is a dissection of this region. This is PDA and middle cardiac vein, and when you follow you can reach to MCV ostium and coronary sinus. You can see that coronary sinus is much thicker than you may expect it. This is coronary sinus, and this is RCA, which terminated in PDA in the interventricular sulcus, and this is crux of the heart. This is IV sulcus, this is AV sulcus, and this cross is called crux of the heart. This article from a Chinese group discuss well about anatomy and imaging of crux area, especially in CT angiogram. You can see that this cross is not a perfect cross and it's a little bit broken. It's not a perfect, it's not a complete crux like this because of anterior displacement of tricuspid annulus. In anatomical cuts, you can see there is a very important contact between RA and LV. There is a direct contact between these two chambers, RA and LV. It's very important to know that because we can use it for mapping and ablation of PVC, as you can see later in my slides. As I said before, there are very important structures in crux area: middle cardiac vein, AV node artery, compact AV node, ganglion plexus between posterior CS ostium and left atrium, and you should be aware of these important structure to avoid complication when ablating Crux PVC or Crux accessory pathways. Let's examine our case vignette. A middle-aged male with frequent palpitation, and you can see there is a wide complex tachycardia with superior axis, and it's a Crux VT. It is my note for scheduling him for Ablation, he was 52, and my primary diagnosis was epicardial VT. I will say why. I have scheduled him for electrophysiology study and ablation with NAVEX precision. I wrote here in Persian that procedure is prolonged and probably it needs epicardial approach. Let's review the literature before continue our case. The first report of ablation of PVC from middle cardiac vein is in 2006, and the first reported epicardial PVC ablation is in 2009 by Dr. Yamada. So you can see that it is not too far from the first reported ablation of this PVC. The best extensive case series is from Marchulinski and Scheinman group in 2014, and they found that about 2% of more than 1,000 ablation for idiopathic ventricular arrhythmia came from Crux PVC. It was the first time that they introduced two types of this PVC, distal crux and basal crux. These are fluoroscopic images of basal crux and distal crux PVC. Here is RAU and LAU view for basal crux, and you can see that they found that they can easily ablate any PVC, any basal crux PVC from middle cardiac vein. But to ablate distal crux, you need epicardial approach, subxiphoid epicardial approach. This is the venogram of coronary sinus. You can see here coronary sinus, middle cardiac vein. This part is called apical or distal crux, and this part is basal crux. This is the most important slide in my lecture. First, you should be suspicious for crux ventricular arrhythmia, PVC or VT, by observing such a pattern in ECG. QS in lead 2 and or 3, R more than S in lead V2, and MDI equals or more than 0.55. If you have such a pattern, you should be suspicious of Crux PVC. Then you should look for left bundle or right bundle pattern. I should emphasize that this left bundle or right bundle pattern could be present in the same patient simultaneously. The step 2 is looking to lead V6. If R is less than S, it is apical crux. So if you have a big S, you have apical crux in both limbs. And if you have big R in V6, you have basal crux. In basal crux, you can easily map it from proximal coronary sinus or proximal middle cardiac vein and ablate it there. But in apical crux, if it is left bundle, you should map first MCV, and then usually you need to go for epicardial surface mapping using subxiphoid approach. In right bundle pattern, in apical crux, sometimes you will be successful for ablation from LV posteroseptal mapping from endocardium or distal middle cardiac vein if you have a big middle cardiac vein. But usually you need again to have epicardial surface mapping using subxiphoid approach. This is a nice case. In anatomical cuts, I said before that there is a direct contact between RA and LV. They found a good signal in LV, early signal, but it was not successful in ablation. But in RA, and you can say it is RA because you have a big A here, you can see a very nice sharp signal, early signal before QRS, before PVC. That was the success point for ablation. Return to our case vignette. He was middle-aged male with frequent palpitation, and this ECG, wide complex tachycardia, superior axis, MDI is more than 0.55, and There is a pattern, there is a nice pattern. V1 is negative, V2 is positive, and V3 again is negative. They call it pattern break in pericardial leads. It's said that it is sensitive and specific for Crux PVC Crux accessory pathway, but like other findings in ECG, it has low positive predictive value for anatomical localization. You can see that in V6 we have big S, so it is an apical Crux VT. So my scheduling for epicardial approach and my primary diagnosis for epicardial VTAC is reasonable. We started mapping from MCV distal. Here, when we enter MCV, the VT terminated spontaneously without it was for mechanical manipulation. You can see there is a very good match here in MCV between pace match in MCV and VTAC. It is 98 match from MCV. We had some burns here, but after that, using isoprostranol, we have VT again induced easily. There is a small change in morphology. It is a little bit more wider. Then we decided to go for epicardial approach. Here my guide wire is passed through epicardium. In this case, the patient had left circumflex artery. The patient has dominant left circumflex artery, and PDA arises from left circumflex. So in this case, we have to inject left coronary artery instead of RCA to protect PDA when ablating. This is the ablation during VT. You can see that in epicardium we had a very good early signal, and ablation there was successful. These are some success points in epicardial ablation, and this is another picture from that. And you can see here the procedure, the summary of the procedure. Burning here in epicardium started with power 35, and it's better to have a much more power, for example up to 50, and termination of the VT is depicted here. For further details regarding this case, please visit cardiocase.com and refer to case number 379 and 380. And last but not the least is possible complication of Crux ablation. First of all, AV block is possible. It is not reported yet, but could happen, and maybe it happened but not reported. Coronary occlusion is reported. In this case, it was a child that has occlusion of PDA during ablation of Crux PVC, and ganglion plexus ablation is also possible. Esophageal fistula is a dangerous and potentially mortal one, and is reported by Dr. Gunesh in 2015. Take-home messages. The crux is complex anatomical area, and you should know this complex anatomy to ablate PVC and accessory pathway arising from this area. Keep in mind that the morphology is indicative of the crux region. It is QS in 2 and or 3, R more than S in lead V2, and MDI equals or more than 0.55. And finally, meticulous mapping of all related structures is needed. Don't forget to map right atrium. Thank you for listening.